For the hip adductors, adductors, the patient be laying on their side with the testing leg on the table, and their other leg would be out of the way in front of them. I would stabilize the pelvis and have her bring her leg up. Go ahead, back down, and then I'll resist proximal to the knee at the distal femur. So go ahead. Good. Can you flip over? Same position. I won't be in the camera. I'll just stabilize on the opposite side. Stabilize the pelvis and the distal femur. I have her do it herself. Go ahead. Back down. Go ahead. Good. Equal force on both sides.
For the adductor group, this includes the adductor longus, brevis, and magnus, as well as the pectineus and the gracilis. They are most commonly innervated by the obturator nerve at levels L2 through 4, but the magnus has some sciatic nerve involvement and the pectineus has some femoral nerve involvement. They work to adduct the hip, internally rotate the hip. They assist with hip flexion. The magnus assists with hip extension, and the gracilis also assists at the knee for flexion and internally rotating a flexed knee. The magnus, the brevis, and the gracilis originate at the inferior ramus of the pubis. The pectineus originates at the superior ramus of the pubis, and the longus originates at the pubic tubercle. The magnus inserts into the medial lip of the linea aspera, as well as down at the adductor tubercle. The adductor longus inserts into the medial lip of the linea aspera. The brevis inserts into the pectineal line, as well as the medial lip of the linea aspera. The pectineus inserts into the pectineal line, and the gracilis inserts into the pes anserine region on the tibia. The patient is side lying on the affected side. I would stabilize the pelvis and resist at the distal femur. The movement, I would just have them adduct their hip or bring their leg straight up. And any compensations to look out for would be to flex the hip or bend the knee to shorten the moment arm.
Alright, to manual muscle test the glute med, I would extend the patient's hip, stabilizing the pelvis, and tell her to raise her leg up to the ceiling with her toes pointed up. Go ahead. Alright. And then I would resist at the distal femur above the knee. Go ahead. Alright, and then can you flip over? You got it. And I'll do it over here so I'm not in the way of the camera. Same thing, extend the hip, toes up, and raise her leg up. Alright, and then resist down here. Go ahead. Good. Don't fall.
For the glute med, it acts to abduct the hip, flex and extend the hip depending on the fibers that are being used, and internally and externally rotate the hip, again depending on the fibers that are being used. It is innervated by the superior gluteal nerve at L4 and 5 and S1. It originates at the gluteal surface on the ilium just below the iliac crest and inserts into the posterior aspect of the greater trochanter. The patient would be side lying on the unaffected side or on the untested side, with the testing side being up. I would stabilize the pelvis and resist at the distal femur. I would passively extend the hip a little bit and have the patient point their toes up towards the ceiling or externally rotate their hip and bring their leg up. Any compensations would be flexing the hip to bring in more abductors.
Alright, to manual muscle test the sartorius, I'm going to have the patient bring her leg into a figure 4 position with this one. Go ahead. Alright. And then I'm going to resist the anterolateral thigh and the anteromedial lower leg. And I'm going to resist her that way. Go ahead. And I'm going to do the same thing on the other side. Bring this one up. Same resistance. Go ahead. Good.
For the sartorius, it flexes the hip, abducts the hip, externally rotates the hip, as well as flexing the knee and internally rotating a bent knee. It's innervated by the femoral nerve L2 through 3. It inserts in the pes serine and originates at the ASIS. The patient can be either seated or supine. I would stabilize. There's no stabilization point. There are 2 resistance points at the medial ankle and anterolateral thigh. I would have the patient bring their leg into a figure 4. Any compensations may be using the other leg to push off, or not completing the motion in one. I'm not completing the test in one swift motion.